Hello, I'm Ann Stevens from Seattle Children's Hospital. I'm here at the RWCS meeting, and I just gave the pediatric rheumatology update. Today we talked about juvenile idiopathic arthritis classification. We have a classification system for JIA that is based on what we see in the clinic. If you have 5 joints, you have poly-JIA, less than 5 joints, you have oligo-JIA, and so forth. This system was established in 1999, and we've been using it ever since. New data over the last few years suggests that by looking at the biology of disease, that we need to reclassify our patients into different categories, and that the new categories are very compatible with the categories that we see in adult rheumatoid arthritis patients. And in fact, juvenile arthritis patients may not be so different from adult rheumatoid arthritis patients. For example, if you look at genetics, children older than 6 years old with rheumatoid factor positive disease are very similar genetically to adults with RF positive disease. In contrast, children with RF negative disease are very similar to seronegative adult RA patients. We see these differences in the older kids older than 6. If we look at children less than 6 years old, all bets are off. Children less than 6 years old are quite different genetically and biologically than adult patients. And this is true for JIA. This is also true for lupus and for systemic sclerosis. Children diagnosed at an early age with these diseases have a higher genetic load, far more autoimmune-associated genes, and they have worse outcomes, more severe disease, they need more chemotherapy, and they have more morbidity and mortality. So we're hoping that the next stage of JIA research will help us through looking at cellular phenotyping, gene expression phenotyping, and genetic phenotyping. It'll help us to classify patients so that we can use these biologic classifications to predict prognosis in children and to better predict who's going to respond to which treatment. The final point I made today was that a child being evaluated by a rheumatologist needs to be evaluated initially with the pediatric focus, because the differential diagnosis in children is very different than the differential diagnosis in RA, in adults. For instance, children with swollen joints have more frequent rheumatic fever. They have a higher chance of having malignancy underlying their disease. And the cases I presented today were 4 cases that we've recently had in Seattle, Washington, of children with swollen, painful joints who actually have an underlying disease of scurvy or vitamin C deficiency. So that's the pediatric update. Mahalo and aloha.